Good morning, everyone, and welcome to today's webinar, Age and Fertility, presented by Dr. Adrienne Neithardt from Delaware Institute for Reproductive Medicine and Boston IVF. Before we get started, I would like to go over a few quick items about today's event. First, all physicians in attendance today will receive an AMA PRA Category 1 credit, and all other providers will receive a certificate of completion for 1 contact hour credit. The certificate will be emailed to you by Harvard around midsummer. Now, without further ado, I would like to introduce today's speaker. Dr. Adrienne Neithardt is board-certified reproductive endocrinologist at Delaware Institute for Reproductive Medicine and Boston IVF. Dr. Neithardt received her medical degree from Georgetown University School of Medicine, completed her residency in obstetrics and gynecology from the McGaw Medical Center of Northwestern University and Prentice Women's Hospital and Maternity Center, and her reproductive endocrinology and infertility fellowship from the National Institute of Health in Northwestern Memorial Hospital. Dr. Neithardt has been a recipient of numerous recognitions, including 5 consecutive Exceptional Women in Medicine distinctions, 4 consecutive Delaware Today Top Doctor Awards, 3 consecutive Philadelphia Magazine Top Doctor Awards, and 6 consecutive Castle Connolly Top Doctor Awards. Dr. Neithardt specializes in all facets of fertility treatments and family building care. We encourage you to submit questions to Dr. Neithardt using the questions and answer box section of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the question and answer session at the end of today's presentation. All right, we're going to get started. I'm going to pass it over to Dr. Neithardt.
Great. Thank you so much, Alyssa, for such a nice introduction. And thank you for everybody for taking some time out today. I know during a busy day and your coveted lunchtime to learn a little bit. So as Alyssa said, the topic today is age and fertility, which I think, especially for female reproductive aging, is still one of the biggest issues that we battle and that is difficult to overcome. So let's learn a little bit about it. Just going to bring you back a little bit to embryology and talk about initial ovarian development, starting with germ cell differentiation, follicular growth, what happens pre and post birth, and then continued follicular atresia. So for one of the first events of sexual differentiation that occurs, it occurs as early as the 2-cell stage of the zygote, and that's the random inactivation of one of the X chromosomes. And that occurs in all somatic cells, but not in the germ cells. Those germ cells then, starting at about 4 to 8 weeks of gestation, migrate from the yolk sac to the gonadal ridge. And if there's 2 X chromosomes and we don't have Mullerian inhibiting substance, otherwise known as anti-Mullerian hormone, which comes from the Y chromosome, then we're going to get differentiation of those germ cells into primitive oogonia. And that starts as early as 6 weeks gestation, right around the same time that we're starting to see fetal cardiac activity. Just a little bit of a flashback here. Let's talk a little bit about oogenesis as well as what's concurrently happening with follicles. At the top of the slide here is all pre-birth. And I think this is really important to remember in contrast to spermatogenesis, in that the only time the eggs, the primitive eggs, undergo mitosis or replication is pre-birth, prior to about 20 weeks gestation. So the initial oogonium, which is haploid, undergoes mitosis, and then it is arrested in prophase 1. Anyone who has to take CREOG exam or REI boards, definitely, these are kind of those buzz phrases that we need to remember. It remains arrested in prophase 1 until puberty, until we have ovulatory cycles. In the follicle, that mitosis, those primitive oogonia are growing in primordial follicles. After birth, until puberty, that primary oocyte and that primary follicle is basically inactive. Starting just before puberty until puberty, we start to have kind of this wake up a little bit. The primary follicle starts to grow. And then once we go through puberty, we start to have ovulatory cycles. The primary oocyte undergoes meiosis 1 kicks out the first polar body, and then we have the secondary oocyte. That secondary oocyte, which is initially contained in a mature follicle and then is ovulated, is arrested in metaphase 2 until fertilization. So ovulation is the completion of meiosis 2, or I'm sorry, is initiation of meiosis 2. It gets halted in metaphase 2. We kick out the second polar body, and then we have, if fertilization occurs, we have the zygote and completion of meiosis. If anyone has seen embryology records from an IVF lab, you'll see us notate when we retrieve eggs, you'll see us notate M2 is what we consider mature eggs, and that stands for metaphase 2. And then we fertilize them with sperm, and the next day we can see a 2PN, meaning we can see two pronuclei, one from the sperm, one from the egg in the zygote. Along that same line, this is a study done years ago by Baker, looking at, again, the number of eggs or oogonia that we have throughout our lifespan. And you can see here, this line right here is birth. So this big spike is mitosis. That's when we're gathering eggs, and we reach our peak number of eggs at about 20 weeks gestation. Baker estimated that to be about 7 million total. I've seen other estimates as high as 20 million, but all of them, we note that it peaks at that point. By the time a female is born, we're already down to about 1 to 2 million eggs. So as soon as we make eggs, they're undergoing atresia, and that continues and accelerates throughout our lifetime. It's estimated that by the time we go through puberty, we're down to about 400 to 500,000 eggs. By the time we're 30, we're down to about 100,000. And an average woman throughout her reproductive lifespan only ovulates anywhere from 500 to 1,000 mature eggs. All right. This is just another way of depicting the same thing, looking at primordial follicles in the ovary and age. Multiple studies that have looked at that. Again, from birth into our 20s, we get a slight decline into our 30s, and then we get a rapid decline in the number of primordial follicles until eventually we don't have any more and we undergo menopause. And it's just marked to note here that that follicle depletion really accelerates in the decade or so preceding menopause. Well, how does this translate to fertility rates with a reproductively aging female? Well, we get a decline in natural fecundity, meaning the percentage chance of pregnancy occurring any given month, as early as the late 20s, but that significantly accelerates in our late 30s, such that by the time we're in our mid 40s, unassisted conceptions and actually assisted conceptions with autologous eggs become very rare. This is, again, just highlighting that these are multiple different studies done at different places in the world, looking at populations of people that are very isolated, generally continue to have babies until they stop, don't use birth control. A famous one from the US that we were always kind of taught during residency was the Hutterites. And again, what's marked in all of these populations, when you follow couples out as they naturally reproductively age, the likelihood of pregnancy declines with age until eventually it becomes zero, even before menopause. We've also been able to prove this by multiple other studies. An example is one by Schwartz et al. That was published in the New England Journal of Medicine back in 1982. And they looked at about 2,000 women who were undergoing anonymous donor sperm due to male infertility. So they were trying to control female age, knowing that you're going to take a supposedly fertile male with normal sperm counts, and what are the pregnancy rates? Well, and they followed these women over a course of a year doing 12 inseminations, and found that, again, as we would expect, and it seems so obvious to us now, but I don't think it was always quite as obvious, they saw decreased cumulative pregnancy rates as a woman's age went up. such that under the age of 26, there was about a 75% chance of pregnancy over 12 cycles. And by the time you're over the age of 35, that decreased to 54%. They didn't really break it down further than that. We also see this with IVF. If you look at IVF statistics, this is preliminary SART data from 2022, and this is national data. So every clinic in the country that reports to SART, and just taking an aggregate of this data. And you can see, if you look at live birth rates, how it declines with increasing age. You go from a 43% national chance of live birth with IVF under the age of 35 to over the age of 42 being only about 3%. And how, again, do we know that this is mostly the egg? Well, if you look at a donor egg population, and you look at women's age here on the horizontal axis, and live birth rates here vertically, we can see when you're using autologous eggs with the red line here, as we've shown in the other slides, live birth rates go down until eventually it reaches 0. But if you look at a donor population, meaning women who are using eggs from a woman under the age of 30, we see that pregnancy rates are pretty constant no matter what the maternal age is. So not that we can discount uterine factors or other ancillary factors, but this again is just showing us that the egg is the biggest contributor to all of this. So factors that contribute to fertility decline with age. Well, I already just spent this much time talking about that. A lot of it is the decreased quantity of eggs, just the way that we're set up. We also see increased aneuploidy rates and decreased oocyte confidence, and that leads to decreased implantation rates and increased miscarriage rates. So let's look at that a little more closely. Most fetal aneuploidies that are analyzed after, say a miscarriage and analysis of products of conception, 90% of them are found to be maternal in origin. And I quoted a specific study here, but this has really been shown in multiple studies. The leading theory is that it's mainly due to chromosomal missegregation during meiosis 1, but it also could occur during meiosis 2 or downstream. What does decreased oocyte confidence mean? So as the eggs age, because as I said, we grew them when we were a 5-month-old fetus, and those eggs now are there the whole time, we do see natural aging that goes along with them. And one of the things that probably impacts that significantly is mitochondrial dysfunction. Our mitochondrial DNA lacks protective histones. They don't have as efficient DNA repair mechanisms as nuclear DNA does, so they're more susceptible to damage. And it's been estimated that mitochondrial DNA mutation rate is 25 times higher than the mutation rate that we see in nuclear DNA. And so the longer the time goes by from when that egg was created to when it's being used again, that rate of damage goes up. They've also shown decreased concentration of mitochondrial DNA in women as they age. We also see shortening telomeres, which may contribute to chromosome missegregation, cohesion dysfunction, and spindle instability. And again, all of these things contribute to chromosome missegregation and decreased egg competence, meaning the egg is less efficient at doing its job, which is, creating an embryo and implantation of that embryo. We also have PGT-A data to back that up. We're going to talk a little bit more about PGT-A in a little bit, but PGT-A stands for Pre-Implantation Genetic Testing for Aneuploidy Screening. This is employed during IVF, where we can biopsy embryos and we can look at the chromosomes. And we, in multiple studies, multiple genetics lab, have all demonstrated that we have higher aneuploidy rates in embryos as the egg age goes up. What other factors contribute to fertility decline with age? So we also have increased comorbidities as we age. We're more likely to have fibroids in the uterus, coexisting medical problems, perhaps decreased coital frequency in aging couples, the risk to pregnancy, so increased risk of miscarriage, poor pregnancy outcomes, all of that is going to increase also. So although I put a lot of stress on the egg and it's all the egg, we know it's not the whole story or the end of the story. So all of these are important factors. And then what about paternal age? We spend so much time talking about maternal age and the age of the egg and what impact that has. I really think we haven't given enough focus on the impact of paternal aging. And we really can see men at extremes of age who are reproducing, and how do we guide them? Well, unfortunately, it's not as well studied as female age and the impact of fertility and pregnancy outcomes. So it's a little more difficult to counsel couples. However, there does appear to be an increased time to pregnancy and decreased overall fecundity in couples where men are over the age of 40 when you control for female age. So there is an impact on male age on fertility. We've also shown that there's an increased risk of, increased chance of having sperm abnormalities, whether it's on conventional semen analysis or something called a DNA fragmentation index, where you're analyzing the sperm for a percentage of the sperm that is fragmented, which also might impact the ability of that sperm to fertilize the egg and create a competent embryo. And also it's been demonstrated to see genetic alterations in sperm DNA as men reproductively age. So let's talk about that for a minute. So genetic alterations in sperm DNA are seen. The overall absolute risk to the fetus is actually very low, but it's not zero. We see an increased chance of de novo autosomal dominant mutations in men as they reproductively age. And more pointedly, we see an increased risk of point mutations with increasing paternal age. And this gained, I don't know, maybe almost about 10 years ago, this made national headlines because there was a New England Journal article that was published that showed an potential increased risk of autism spectrum disorders in men of an older age. And this kind of blew up on the nightly news and created a lot of phone calls to our office. In general, yes, this is seen. In general, the absolute risk, I should say, is small. So these point mutations that can occur, and you can see that in autism spectrum disorders, schizophrenia as examples, are small point mutations in the DNA, which along with epigenetic factors may contribute to a slight increased risk of these disorders. A good way to think of it, with the egg undergoes mitosis for a short period of time. And the sperm, however, is made over and over and over again for the whole entire reproductive lifespan of a male. So there was a study that looked at this, that estimated a sperm from a 70-year-old male has probably undergone 1,300 mitotic divisions if they started puberty at the age of 15. So think of it as taking a photocopy of a photocopy of a photocopy of a photocopy. And right, you lose resolution downstream. So that might be, it's more subtle than that, but there are changes that occur. And I still think it's important conversations to have. Also, some studies show that maybe there, even aside from genetic changes, there may be a slightly increased risk of congenital abnormalities. It's hard to differentiate. Often in couples where there's reproductive aging of both members. So sometimes it can be difficult to really ferret out. It's so multifactorial. So what diagnostics are out there? What kind of treatment? What are we going to do for women or men who are reproductively aging and want to kind of assess their options? So I'm going to go over kind of what current ovarian reserve testing looks like, basic fertility evaluation, talk a little bit about egg freezing and IVF. So an evaluation, I think what's important to distinct is an evaluation for somebody who already is experiencing infertility versus trying to assess ovarian reserve just baseline. And the reason I make that distinction is that there's no real test for fertility. You know, you can do these tests and someone's numbers can turn out very reassuring, and it does not guarantee that they are going to get pregnant or they're going to be fertile, and vice versa. You know, I could test, and we're going to talk about these more in detail. I could do these tests and it could show that, geez, there's lower reserve in the ovaries that does not equal infertility. So I think it's really important to make that distinction. And if I see a 39-year-old woman who's never tried to get pregnant, has amazing ovarian reserve testing, I'm not going to tell her that everything's going to be okay, because the age is the biggest predictor, no matter what any of these others numbers show. And ovarian reserve testing might be okay right now at 39 and 0 days. And by the time you turn 40, your window is already closed. And that's really difficult to predict. So we always have to take this with a grain of salt. So what is ovarian reserve testing? Ovarian reserve testing is trying to assess the quantity of the eggs that are there in the ovary at a given time. And as I mentioned, it's not perfect. You know, when a man gives a semen analysis, we can count how much moving sperm is there. We can't do that with the eggs. So we're looking at indirect measures to try to look at that. So blood work that we do, AMH, which is anti-Mullerian hormone, we use as a marker. If you look at just the general female population, AMH starts out high when we're young, and it naturally declines as we reproductively age. But as I mentioned, a low AMH alone does not equal infertility, nor does a high AMH equal fertility. It is highly associated with how a woman may respond to fertility drugs. So if someone's considering freezing their eggs and they're going to undergo treatment, and we want to see what's the likelihood of us being able to get a good number of eggs to freeze, AMH is very good at predicting that, but it cannot predict pregnancy. Along with AMH, we do a day 3 FSH, which needs to be done with an estradiol level. So FSH levels early in the follicular phase do correlate with ovarian reserve. And the higher the FSH, the lower the ovarian reserve, the poorer the prognosis. So we like to see it a 12 or below. But if you check an FSH and it comes back 6, but the estradiol level is 180 in the follicular phase, where it really should be ideally less than 60, well, that estradiol is causing feedback to the FSH. So the FSH is artificially lowered. You really can't interpret it in that situation. And an elevated early follicular estradiol is another independent predictor of diminished reserve. So always get the two together so you know that you're interpreting it at the right phase of the cycle. And along with that, we do an early follicular antral follicle count. Our antral follicles, so if you look at this little thing to remind you about oogenesis again, so our primordial follicles, that's what we grew at 20 weeks gestation, and it grows into a primary follicle, and then it stays there until it's recruited that month to be released. The antral follicles are the secondary follicles that now are sensitive to hormones, FSH and LH. These follicles down here are not responsive to gonadotropins, so they're growing independent of those. By the time you get here, these follicles can be recruited by gonadotropins, so that's how IVF works. When we give high doses of FSH and LH, we try to recruit these antral follicles now to grow and produce a mature egg. So if you look basal at the number of antral follicles, you can see that on transvaginal ultrasound, that number correlates again to ovarian reserve. So we do all these things together to try to get an overall picture of what someone's reserve looks like. An antral follicle count that is adequate, most studies show that 10 or above is an adequate range. Between 5 and 10 is gray, and 4 or less is a sign of diminished reserve. I also think it's important, if someone's interested in fertility or infertile, to look at everything. Don't ignore it. You know, you don't want to get further out, whether it's fertility treatments or you let them go too long and then you find out, geez, their partner doesn't have any sperm or their tubes are blocked. So I think assessing other fertility factors at the same time, tubal status, uterine anatomy, if they have a partner, checking sperm to make sure there aren't other confounding factors that may impact their fertility. And in the same fashion, this is the opportunity now to optimize and address any underlying medical problems or lifestyle factors that may negatively impact their current or future fertility. So let's move on to treatment. So as I was just discussing, certainly addressing and treating any underlying medical problems, hypertension, diabetes, thyroid disease, trying to optimize weight, decrease toxin exposure, meaning tobacco, marijuana, alcohol, utilizing that to improve the likelihood not only of getting pregnant, but also decreasing pregnancy complications. I have a question mark by supplements because this is a huge industry, as you can imagine, and really appeals to people. Really, the only supplement that we know that has any impact on pregnancy is folic acid. We know that preconception use of folic acid reduces the risk of neural tube defects. All the other stuff out there, the evidence is not great. But I see, 90% of patients I see come in and they're on, not just their prenatal vitamin, but they're on coenzyme Q10 because they heard that that's going to improve their egg health and various other supplements. And it's really difficult to really know and sort that out. There's some not great evidence that coenzyme Q10 may help with egg quality. Again, it's such a hard thing to study. We know that CoQ10 is important and is lost in aging eggs, but I have yet to be convinced that taking it orally is going to replace that or prevent that. Fertility preservation. So what does that mean? So for any couple or any single woman or single individual who are aging and aren't interested in reproducing in the immediate future, I think it's very reasonable to have a discussion about what can you do to preserve your eggs and or sperm. I talk a lot more about eggs here because that's a lot harder. And you don't see as men very often, unless they're going to undergo medical treatment that's going to be gonadotoxic, coming in for elective sperm freezing. But maybe that is a discussion we should be having more as men are approaching 40. Do they freeze sperm to use for the future? And again, I think there's not specific answers for that yet. So let's look at the female. What can you do? Well, there's egg freezing and embryo freezing. For either option, the younger you are, the younger the egg is at the time you do that, the better outcomes you can expect. So we use fertility preservation. It's been widely used in women who are going to undergo any sort of gonadotoxic therapy, chemotherapy for breast cancer, say, radiation. But we're seeing it more and more in women who are they're either proactively delaying childbearing or they're not at a point in their life where they can, and they're worried about their future fertility. Of course, it's expensive. It does require a minimally invasive procedure along with anesthesia to get the eggs. And I always want to stress that there is nothing that's a guarantee. Actually, let me go back for a second to talk a little bit about egg freezing versus embryo freezing. Prior to 2012, the only option we had electively was embryo freezing. We weren't very good at freezing and thawing eggs. It was only done under research. And so we do know that if you freeze an embryo, it has a very high survival rate when you thaw it. If you've got a good quality embryo with the techniques that we use nowadays, there's a 98% chance it's going to survive the thaw, and it has very predictable implantation rates. However, the downside of creating an embryo is that if you don't have a partner or a partner that you want to commit to yet, well, once you've created those embryos, they're both of your property. So egg freezing has a lot more advantages as far as women being able to make decisions. And some people feel ethically better, if they don't need these in the future. Some people feel better about discarding eggs rather than embryos. So egg cryopreservation prior to 2012 was only done for research purposes or in cases of, say, oncofertility, a woman who needed to preserve her fertility because she was going to undergo chemotherapy. But within that world, we developed and optimized a technique called vitrification. And it's a technique that is utilized now to freeze eggs and embryos. And it's a rapid freezing technique, and it's associated with much higher survival rates of eggs and embryos compared to older methods. National data right now is that when you have frozen eggs, about 93% of them are going to survive when you thaw. Fertilization rates, blastocyst development rates, and pregnancy rates are very comparable to fresh when you utilize fresh eggs. And most importantly, neonatal outcomes appear to be similar. So this is a viable option for women these days, but it is expensive. One thing to see here, this graph, which I know can look a little bit busy, this is looking at number of mature eggs you have frozen and the probability of having at least one live birth, and then the graph is different ages. And really what this is illustrating is the older you are at the time you freeze your eggs, the more eggs you need to achieve one live birth. So for instance, this line here is 44. So if you've got 20 eggs, which is well above average, frozen at the age of 44, that still only gives you about a 15% chance of a live birth. Whereas if you're young, under the age of 35, you've got 20 eggs, this curve is showing you a 90% chance of one live birth. And for a 44-year-old to get, that, let's see, even 50, you need mature eggs to get a 30% chance of pregnancy. And you need 100 mature eggs to get up to 50% chance of pregnancy. And that just doesn't happen. The same women who, as you reproductively age, you need more eggs are the same women who don't produce as many eggs at one time. And that's why I stress that, egg freezing is better the younger you are. We do have models to help predict what your chance of success is. They're just mathematical models. But again, the data is not perfect on that. Let's see. And then to continue our discussion on different treatment options, let's talk about infertility treatments in general. The idea of infertility treatments, if the only issue is reproductive aging that we can identify, the real aim of treatment is to increase fecundity, meaning increase the percentage chance any given month that pregnancy is going to occur. And there's different ways that we can do that. Superovulation means taking oral or injectable fertility drugs to try to get more than one egg to be released at a time. When it's done alone with timed intercourse, probably gives very little overall increase in pregnancy rate. Adding an IUI in it, again, is just trying to increase that overall chance of pregnancy. IVF with or without genetic testing, which we're going to talk a little bit more about. So which do you do, IUI versus IVF? Well, Boston IVF did a study several years ago. It was called the Fast Track study, and it was a randomized study. And they randomized women undergoing kind of conventional treatment where they took oral drugs with IUI, then injectable drugs with IUI before moving on to IVF versus a group that went directly to IVF. And what they showed is that, you did not get a big increase in the per cycle chance of pregnancy until you went to IVF. So in women who were doing Clomid or FSH with IUI, the chance of pregnancy was only about 8% or 10% respectively each cycle, and IVF, it was about 30%. And so really this was one of the first studies to really show us that, okay, in all patient ages, IVF generally has a shorter time to pregnancy and live birth and better pregnancy rates. There was another a systemic review that looked at, I think they were 42 studies were included, this Nesbitt et al. So they first looked through 636 different studies were screened. They ultimately included 42 different ones. About 8 studies actually included live birth rates. And again, it was comparing success rates with IUI versus IVF. Majority of pregnancies that occurred with IUI did so within 3 to 6 cycles. But if you look at the change, and this is just an example of 2 of the studies that they included, the difference here in live birth rates per cycle is huge. And this was all women over the age of 40 only. So this was not all comers. So in this one study, you had a 3.2% chance of pregnancy each month versus a 15% chance. This one was 1.3 versus 9.2. So really what it's showing us is that while pregnancy can occur with IUI, especially the more that you do, it's going to take longer to get there. And my biggest concern in women over the age of 40 is that your window to intervene is going to close before you get to IVF if you delay too long. This is another study done by Boston IVF, and this was looking at outcomes with IVF in women over the age of 40 specifically. And again, you can see the natural decline here, even with IVF. At the age of 40, there was about an 18% chance of obtaining a clinical pregnancy. And by the time you were 45, it was just over 5%. And what they found in this study is that by the age of 46, pregnancy rates are really close to 0. But it tells us that there's time to intervene here in these years. These are big years, and you don't want to delay too much longer. Well, how do we address the increased rates of aneuploidy seen in reproductive aging in women? We can't change it. We can't make an embryo at this time euploid. But during IVF, you can have the option where you can screen the embryos you produce to make sure that the embryo that you're transferring back to the uterus is euploid. And what this consists of, the embryos are created through IVF and grown to the blastocyst stage, which is what this is showing. The blastocyst is made up of this area of cells, which is the inner cell mass and is destined to become the actual fetus, and a rim of cells around the outside called the trophectoderm cells. And before the embryo is frozen, the lab biopsies somewhere between 3 and 10 cells from the trophectoderm. The embryo is then frozen by vitrification, and the DNA is isolated from those cells and sent to a genetics laboratory that does an analysis. And most of them use some form of next-gen sequencing. And what that allows us to do is, if a couple is fortunate and there's 5 blastocysts that are created, we know aneuploidy rates are going to be well over 50% in 50% or above in the 40s. If you can screen those embryos and you say, okay, out of these 5, there's only 2 that are euploid, let's select one of those 2, we significantly increase the odds that implantation is going to occur and live birth is going to occur. So you can take miscarriage rates from an average of 25% in your early 40s and decrease the risk of miscarriage to about 8 to 10%. So PGT, it's a tool. It is not perfect, and it helps us select the embryo that has the highest chance of making it to a live birth. But it depends on being able to make embryos. So the same patient population that really can benefit from doing this technology often doesn't respond as well, may not make as many embryos, and that can really be a limiting factor because it sounds great on paper. So when you look at the pros and cons of PGT, just a very cursory explanation. Oh, this is backwards. I apologize. I had it switched and it switched back. So this should be cons here. So the downside is that it adds an additional expense to the IVF cycle in order to do that testing. You have to be able to culture and have enough embryos that you can culture them out to the blastocyst stage. And there's a very small chance of discarding viable embryos. And I think the better the science has gotten, that risk has gone down. But we know that mosaicism occurs in the trophectoderm, meaning there can be normal and abnormal cell lines that occur together, and meaning that we could get a test result based on those 6 cells that we tested. Okay, maybe those 6 cells were abnormal, but it's not representative of the fetus. And so we usually quote about a 2% risk of discordance between what's actually going on in the fetus and what's going on in the placenta. And so there is a very small chance you could discard a potentially viable embryo. Well, what are the pros? There are much higher implantation rates when you transfer back a euploid embryo. you have lower miscarriage rates, and that often will result in long-term cost savings because you're not doing as many embryo transfers, you're not experiencing as many miscarriages, and there's a huge emotional component to that also. I already showed you this slide before, but again, for couples who desire or women who desire still to be pregnant but are not able to produce their own embryos or have not been successful, donor egg or donor embryo is an option. And again, it maintains very high pregnancy and live birth rates, even up to more, even postmenopausal, honestly. What are some things on the future horizons? Because all of these treatments that I've talked about, nothing is aimed at preventing the eggs from aging or preventing us from losing eggs, per se. People have looked at this in varying ways. In vitro maturation of oocytes, meaning if we can retrieve a primary oocyte, an immature egg, or take ovarian tissue and then grow those eggs in the laboratory, that would help us overcome the problem of women who don't respond to the fertility drugs anymore, but we're not able to get mature eggs. This is very difficult to reproduce and really hasn't hit prime time. Intra-ovarian PRP infusion, this is being done in some centers and some research studies. PRP is platelet-rich plasma infusion, where you take blood from the individual, the platelets and plasma is isolated, and then you infuse that back into the ovary, and the thought is to kind of rejuvenate the ovaries. And initial studies, it hasn't seemed very promising yet. Stem cells are very similar. Mitochondrial transfer, this one I think is very interesting, and people may remember these headlines from a few years ago. A baby born from a new IVF procedure from 3 parents, and of course it was very sensationalized, but what they were talking about was using mitochondria from a donor, a young egg donor, in this case it was done to help prevent transmission of mitochondrial genetic disease. So this is where it was initially done, but people have expanded that and have tried to use it for couples who have reproductive aging. It's not undergoing in the US anymore. The studies in the US were stopped. And I think there's been some issue, at least from the genetic standpoint, that, initially people were very excited you could do this mitochondrial transfer. They found that the maternal mitochondria were less than 1%, but what they saw is even after children were born, you get the maternal mitochondria regenerating, and there was about a 20% reversion rate. And so it's really called into question the ethics of this. But it's I think very interesting, and maybe at some point for reproductive aging may be able to play a role if we can figure out how to do it safely. So in conclusion, basically reproductive aging is one of the biggest factors that impacts ability to have a live birth for women as we reproductively age. My advice would be for any women that you encounter who, even if they're not trying or they don't know when it's going to be, having a discussion about the reality of what reproductive aging does to your fertility potential, and referring to a reproductive endocrinologist to discuss options. I've never had a patient regret having a discussion. People only regret if the window's closed and they haven't had that opportunity. So hopefully that all made sense, and I'm going to turn it back to Alyssa, and we'll take any questions.
Thank you, Dr. Neithardt. We are now going to begin answering questions submitted during today's presentation. As a reminder, you can still submit questions through the Q&A button in your attendee control panel. Dr. Neithardt, our first question is, what is the cost of egg freezing?
I know, right? Cost is the hardest part of it. I think it's really going to vary. It's going to vary in the area of the country that you live in, the clinic that you go to. It's rare to have insurance pick up the bill for egg freezing. I run into more people though who have programs at their jobs, at their companies, that offer reimbursement, but I still think it's far and few between. So egg freezing, I mean, it can cost anywhere from $10,000 to $20,000, or $8,000 to $20,000, depending on where you are and how much medication you need. And I think that's really the biggest hurdle for access to care, because you're asking, who do you want to freeze their eggs? Women under the age of 30, under the age of 35, the same people who really just don't have necessarily those means to do it.
Thank you. The next question is about egg freezing as well, and it's asking, do you recommend egg freezing for the daughters of women with POI, and what age-ish?
Yeah, that's a great question, because we do know that, so POI is premature ovarian insufficiency, which is multifactorial. We don't often know the exact cause of it for an individual, but we do know that it can run in families. So if mom goes through early menopause or has premature ovarian insufficiency, there is a higher risk of her daughters having the same thing. So I think it's a very reasonable thing to consider, in a perfect world, in your 20s, 25 to 30. Definitely freezing your eggs before 35. That's the best prognostic group of women under the age of 35. But if there's premature ovarian insufficiency in the family, I'd say, okay, what age did that occur for you? And back up 5 years or more and try to look at it before then.
Great. Our next question is, what about ovary PRP and egg quality? Is it improved quality in embryo euploid?
Yeah, so PRP, and again, the studies out there are not great, and it's still, I think, more theoretical. It's not going to change euploidy rates. I think the idea of PRP is to hopefully help a woman respond better to stimulation, so you can get the eggs first. But I think we can't say whether or not it actually improves egg quality at this point, and I don't think it would improve embryo euploidy, unfortunately.
Thank you. Our next question is, how do you counsel young women or women at any age if they come in just wondering what their fertility looks like? Would you do those day 3 labs on a woman of any age?
So I think it's a slippery slope. And I'm sure that general, like family practice, OBGYN, you're getting these questions all the time, and you're getting women asking you to do these things. Not that I wouldn't offer it, because I think, patient autonomy, shared decision-making is all really important, but I would really have a discussion first. If a 25-year-old comes in, wants to check her AMH, again, what are you going to tell her if it's low? If it's high, you can say, okay, that's reassuring, but it doesn't mean you're fertile. And it doesn't mean that you won't be infertile 5 years from now or have a low AMH 5 years from now. And if it's low, are we going to cause duress and stress and it may not even be applicable? So I would have a discussion before offering it and really say, okay, what are you going to do about it if we get these test results back? If your AMH is lower or high, do you want to freeze your eggs? I'd have a little more discussion before just drawing it, because I've seen women come in so stressed out because they had an AMH drawn somewhere, it was low, they've never tried to get pregnant, they're healthy, their antral follicle count otherwise looks good, and I can't guarantee them that they're still going to be fertile, but I certainly can't tell them they're going to be infertile, so it can cause a lot of anxiety.
Thank you. The next question is, what genetic testing do you recommend prior to treatment, or which panel do you use? And do you test the female and male at the same time if you do a larger panel?
Yeah, absolutely. So this has progressed a lot over the years since I've been in practice. I first started, we'd only do like cystic fibrosis, and that was it. And now, we have these huge panels that are out there, because in our scenario where a certain percentage of our patients are going to go through IVF anyway, or we have the option to take them through, I do offer them an extended carrier panel. And the carrier panel we use, I think, tests for like 400 different genes. And I do the partners both at the same time, because with those expanded panels, I think it's at least 30% of people are going to come back a carrier for at least one thing. So there's a really good chance you're going to be screening the partner anyway. And it takes 3 to 4 weeks, and they just get frustrated if their care is being delayed. So I do both of the panels at the same time, or I offer them. Again, it's optional, but I try to have a discussion as to why are we offering this? What can we do about it? Because if we find, and I've seen it quoted, about 3% of couples are going to come back with something in common, a recessive gene in common. Well, depending on what that gene is, we can offer them PGT-M. So during IVF and you create embryos, PGT-M is pre-implantation genetic testing for mutation screening. So if they're both carriers of cystic fibrosis, we can screen the embryo and make sure the embryo we transfer back doesn't have both of those genes. So anyone who walks through our door, I offer it to everybody. And I think a higher percentage of people do it nowadays than they were doing 10 or 15 years ago. So it's a good question.
Thank you. I have one more question. When using donor eggs, how does the recipient's age influence implantation and live birth rates? And are there any other age-related factors or uterine conditions that should be considered or managed differently for older recipients?
Absolutely. So while, I showed that pretty graph and donor pregnancy rates stay pretty constant, we can't ignore everything else because it isn't just about a positive pregnancy test, right? It's about a healthy baby at the end of the day. I think as we reproductively age, we're more likely to have concomitant problems like fibroids in the uterus, or underlying medical problems. Overall, though, we would, before someone just creates embryos and we start transferring them back, we are going to do an evaluation of your anatomy, make sure there isn't anything structurally going on with the uterus. You can even do a mock prep where we make sure that your lining can thicken up appropriately. We're going to make sure that there's no medical comorbidities, or that if there are, those are well treated going into it. We know that as women go into their 40s, especially after the age of 45, the risk of complications during pregnancy, such as preterm delivery, preeclampsia, gestational diabetes, can go up. And that's independent of the egg there. So, it's important that a woman understands those risks, and that really just has as good prenatal care and preconception care as possible to mitigate that. Every fertility clinic out there is a little different in what age for a woman they'll stop transferring embryos. Boston IVF, it's around the age of 50. Over the age of 50, especially over the age of 52 to 54, the risks or the complication rate during pregnancy really starts to increase exponentially. So every clinic kind of makes a cutoff that they're comfortable with. Most women over the age of 45 will have them have, even if there's no medical history, have like a cardiac evaluation, an EKG, to make sure there's nothing that we're missing before you actually go ahead and get pregnant. But implantation rates are great for a long time. You can be postmenopausal, and we can give you back the estrogen and progesterone to establish a pregnancy. And by the end of the first trimester, the placenta takes over production.
Thank you so much. Thank you, Dr. Neithardt, and thank you everyone for attending today's webinar, Age and Fertility. If you have any questions, please contact myself, Alyssa Cooper, at ecooper@bostonivf.com. Once you leave today's webinar, you'll receive a survey on the presentation, and we would appreciate it if you could complete the survey and provide your feedback to help with future educational webinars. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. On behalf of Boston IVF, Delaware Institute for Reproductive Medicine, and Dr. Neithardt, thank you for joining us, and enjoy the rest of your day. Thank you, Dr. Neithardt.
Yeah, thank you all so much. Have a great day.